Hi everyone, I'm Paul, and for the last year and a half I've been working as an anesthetic and ICU registrar in Galway University Hospital on the west coast of Ireland. In this video I want to talk to you about end-of-life care, withdrawal of care and palliative care. I'm not gonna have this talk all by myself because some people, some more experienced people than I am, have accepted my invitation in this interview. So we're going to talk with Dr. Pat Nelligan, who's also a professor here at the University of Galway, and he's an ICU and anesthesia doctor for over 30 years now, so a lot of experience. And with Anne Gately, who's a very experienced nurse, a very funny one, which I love to work with, and they're going to share with us their opinions on the subjects I've just mentioned. I'm very grateful for them for doing this, and I'm very excited to share this with you. Let's see what this is all about.
We would say to the family, we are going to withdraw life-sustaining therapies because this is wrong, it's unethical, and we're making this patient suffer unnecessarily.
Cardiac cripple, for instance, it's probably the biggest disability one can have, no exercise tolerance.
And you've seen this yourself, you've been here long enough. The nurses will come to you and say, he's not going to survive, this is wrong. And the nurses often start the conversation. And the nurses are continuously talking to the families, and they will often start the conversations with the families. And they're very, very skilled at it.
Most unselfish thing to do for a relative is stand outside and think what you'd want, and then look at them and think, no, this isn't about me, as much as I'll miss them and as much as I'll, grieve them.
It's a hard feeling.
It's a very difficult thing to do.
Yeah. People are, the way the world works, you're kind of forced into making a rapid decision on something, and sometimes you're not in a position to do that.
Yeah.
And so I say, I'm not comfortable making that decision because I don't have enough information, and I need to process this, and I need to spend time thinking about this. Because there's a whole problem of sunk costs where people make a decision, they feel, oh no, I have to go with that because I've made that decision. I don't want to lose face. I don't want to have a reputational damage, and it's called status quo bias.
When you give such news to a family, how do you feel about it?
Oh, I'm very sad for a family. You can always empathise because,
Because I feel sad.
I feel so sad.
And I get it, I don't know what it's called,
A lump in your throat.
A lump in your throat, yeah.
And I sometimes, it's obvious by me.
If I go and talk to a family, I just say it straight up, your mum or dad is dying. The D word, everybody knows what dying means. But to me, I can't imagine a situation where you have people in a hospital ICU bed for weeks or months who clearly can't survive. It's torture, it's horrific, it's the wrong thing to do to somebody. I can't imagine that happening to a member of my family.
Do you have an age criteria for admission?
No.
Yeah, they have in England. I'm not sure about the age criteria.
Yeah.
And of course, when you're in the ICU, every day is it's like dog years. Every day is like a month. You're aging at an alarming rate. Your body is deconditioning. Your organ systems are becoming malfunctional. So after about 4 weeks, your chances of surviving are extremely low.
But I feel, as a nurse, you can prepare relatives for the worst. You can say to them, it's worrying. I am worried about it.
And sometimes I do it myself. I just get attached to a patient, and I find it hard to let go. And luckily somebody comes in and says, no, you're mad.
And I say that, and that's one of the first things I do. Patient settled. I go out and I speak with the relatives, and I say to them, I think the relatives deserve care as well. And I say, he has come in, he's quite sick, but he's stable, he's in the right place. But we are probably going to be about a half an hour.
What's the policy here? I don't know exactly.
Well, my policy is within reason, whenever. As nobody will stop me.
Is there a written policy?
ICU doctors don't get sued. Anaesthetists get sued a lot. In Ireland, we have a very aggressive legal profession who are just looking for cases, but families don't sue ICU doctors or ICU nurses, and there's a good reason for that. Our first wave of COVID, nobody died in our ICU because we didn't get overwhelmed, and we actually gave the patient a lot of time to recover. Yeah, we weren't making that decision, but the problem we had is that we needed to make sure that young people had beds in the ICU. In most health systems, nobody really thinks of the doctors and the nurses in the ICU. They think of this as a ward over there somewhere where really sick people go, but we're not like cardiologists or gastroenterologists that have all glamorous lifestyles and we drive massive cars and have huge houses.
Yeah. So this is one of the facts that I liked the most here like people like you who have a lot of experience,
Yeah.
you're not afraid to admit, I don't know, I was wrong.
For myself, I want to get paid so I can have a decent living and my kids can grow up in a safe place. That's why I live in the west of Ireland. It's a safe place. The weather's terrible, but they have great schools. There's good restaurants. We've good nightlife and stuff.
End of life, end of life. No, I just said what I thought. End of life, definitely. Do not resource. You can't deliver care unless you have hope.
Yeah.
You know, it's like, does the patient hear you? You'd like to think not, but you have to believe they do.